Good evening to all. Welcome to the Registrar Monday evening session. I'm Shiraz Gabriel from Tygerberg Stellenbosch University, and Godknows will be presenting his talk about post-operative recurrence. But before we start, let's do some formalities. So welcome to all. The G-Echo is hosted by the Castro Foundation in association with Project Echo and the University of New Mexico. G-Echo Fellows is run every second Monday at 6 o'clock. The chat will be open to questions. Godknows, the floor is yours.
Thank Thank you, Dr. Shiraz. My name is Dr. Godknows Shamhuyashe. I'm a gastroenterology fellow at Christian Baragwana Hospital. So the talk for this evening is on post-operative recurrence of Crohn's disease. As you know, Crohn's disease is a chronic inflammatory disorder of the gastrointestinal tract, and which has got a relapsing and remitting phases, of which at some point these patients, they might need surgery. So surgery in Crohn's disease is rarely curative, and most of the patients, they'll have post-operative Crohn's disease recurrence. So the post-operative recurrence rates, they vary depending on the modality and definition of the assessment of the recurrence. And so one needs to have a careful assessment to ensure that the symptoms are not due to other malabsorptive or motility issues post-operatively. And the clinical recurrence rates after resection surgery have been reported to vary from 36 to 86% at 10 years of follow-up. So it just depends on the studies, of which we have got various scoring systems which exist for monitoring endoscopic Crohn's disease recurrence, and also the endoscopic recurrence rate after the resection of surgery. And it typically presents as a continuum from histological findings to endoscopic findings and also to clinical presentation. So there's need for an early endoscopic monitoring and prophylactic pharmacological therapy in the post-operative management of patients with Crohn's disease. So what are some of the indications for surgery? So we have got patients who might be having intractable gastrointestinal hemorrhage, those who have complications like fibrostenotic strictures with obstructive symptoms, and also patients who develop intestinal perforation, toxic megacolon, and also those who develop malignance, or some who might have treatment-related complications, including intra-abdominal abscesses, and also in the children, those who have got growth failure, of which the primary surgical procedure is ileocecal or ileocolonic colonic resection. So because of the likelihood of recurrence after segmental resection, the guiding principle of surgery in Crohn's disease is preservation of the intestinal length and function. Otherwise, the patients might end up having short bowel syndrome. So the disease itself, it frequently recurs at the anastomosis and in the neoterminal ileum, which just proximal to it. So Radkes and colleagues, they demonstrated that such recurrence is independent on the presence of fecal content. So if there's stasis of the luminal content at the anastomosis level, particularly in certain times of anastomosis, like the side-to-side anastomosis, it promotes bacterial proliferation and subsequent action of some of the bacteria strains on the ileocolonic mucosa, where there is where the immune system is already primed to trigger an inflammatory response. So this can lead to the recurrence of Crohn's disease. So the natural cause of post-operative Crohn's disease, it's clinically initially it's clinically silent. So within a week after the surgery, you might expect to have histological changes. Then 70 to 90% of the patients might have endoscopic changes, that is by 1 year. And also you can have radiological images which shows some tissue damage. And 30% by 3 years, they will have clinical symptoms, and about 60% by 5 years will have also clinical symptoms, which might need to 50% of them having a repeat surgery. So most of the surgery is usually due to the complications which the patients will have developed, such as strictures, perforation, abscesses, and in terms of the pathophysiology for post-operative recurrence, it can involve the microbiome, the mesentery is also involved, and also the immune system, and also the genetic factors like the NOD2 gene and CAD15 and some other genes which have been found in investigational studies. So there's an interplay within these factors which are responsible for its pathophysiology. So on this diagram, it shows that we've got mesentery fat wrapping with adipocytes and memory T cell infiltration. So the fat wrapping or fat creeping, it's a pathognomonic, which is observation in only seen in Crohn's disease, and it consists of hyperplastic mesenteric adipose tissue that wraps around the bowel wall, mirroring the patchy distribution of inflammation. So in this cytotoxic environment, there's increased mucosal levels of various inflammatory cytokines. So together with patients who are smokers, there's increased of T cell clonal expansion, and you have got inflammatory cytokines secretion, and this leads to intestinal barrier disruption. And we also have some activated macrophages, which can also lead to uh, inflammatory cytokine secretions and also intestinal barrier disruption. So it's an interplay between all these factors, and this can lead to recurrence of Crohn's disease. So the typical symptoms, it involves diarrhea. The patients can have diarrhea, they can have abdominal pains, but one also has to consider other differential diagnoses like irritable bowel syndrome and also bile acid malabsorption. And you find that a subgroup of patients, they will develop stenosis and will need endoscopic dilatation or a second surgery at all. So what are the risk factors for recurrence? We've got patients with lower risk. Those are the non-smokers and older patients who are above 50 years at diagnosis, and also those who have got first surgery for Crohn's disease, and also a short segment of Crohn's disease that is less than 10 to 20 centimeters, and those patients who have got a long-standing history of Crohn's disease more than 10 years. And those who have got moderate to higher risk, patients who are smoking, those with who are active smokers, especially in women, they've got a high risk of having recurrence. So smoking, it has been shown that it increases post-operative recurrence of Crohn's disease by a factor of 2, and also it aggravates the disease course, causing frequent relapses and shorter time to recurrence. So patients also with a prior surgical history of Crohn's disease, those who will have had more than 2 surgical procedures, and also those who have got penetrating or fistulizing disease, and also patients who have got residual luminal disease, and those who are less than 30 years of age at diagnosis, and patients who have got a positive resection margins, and also those who progress to disease despite treatment with an immunomodulator or biological agent, they are at high risk of having a recurrence. But there's no validated clinical score that predicts recurrence currently. There are also other predictors of early postoperative recurrence, like genetics, as I mentioned earlier, and also serology, those who have got a positive ASCA and OMP-C, and also CBIR1, that's the flagellin, and also the microbiome. Those who have got increased E. coli, bacteroids, and fusobacteria have got a high risk. And studies have also shown that patients with low abundance of Faecalibacterium prausnitzii in both the resected and post-operative ileal mucosa are at high risk. And also the characteristic of the histology, the section also increases the risk of post-operative recurrence. You find that patients who have got transmural lesions at the iliac margins, and also if there is mesenteric and submucosal plexitis, and also if there are granulomas in the resected specimen, there's an increased risk of early post-operative recurrence. And also the operative intervention also contributes. The type of surgery, the surgical approach, whether it's laparoscopic or laparotomy, and also blood transfusion requirements. There's an immunomodulatory and oxidative stress associated with it, and also some pro-inflammatory state after blood transfusion, which is activated. And also the excision of the margin length, and also some the peri-operative complications, and also the anastomotic orientation and the technique which has been used by the surgeons can also predict. And also the mesentery itself, excision, the extent of the mesentery excision can also contribute. And also patients with a structuroplasty, a long structuroplasty over the valve, which may be an alternative usually to classical ileocecal resection. So in terms of the type of surgical procedures, we have got the corner S anastomosis, and it has been shown to have a growing interest in extending the mesentery resection. Recently there's been a growing interest in extending the mesentery resection, and also in the corner S anastomosis, which is a hybrid manual and stapled anastomosis based on the concept of mesenteric exclusion. So this photo here just shows the corner S anastomosis, and together with the functional end-to-end anastomosis. And you can see that there's a supporting column on the mesentery side, and that supporting column can present a distortion. So this technique, it permits obtaining a wide anastomosis without a large blind stump. So it minimizes fecal stasis and also bacterial overgrowth, which have got a role in the pathogenesis of recurrence. There were some two meta-analyses which confirmed the effectiveness of Corner S in preventing postoperative recurrence when compared to other type of anastomosis. And it has been shown that it can reduce both endoscopic and clinical postoperative recurrence according to one randomized control trials. So this is one of the systematic review and meta-analysis which was released last year in 2024, of which it was a meta-analysis of 17 studies. And it showed that, in summary, the patients who received Corner S anastomosis, they had a pooled incidence of endoscopic postoperative recurrence of 24.7%, while at least those who received conventional anastomosis endoscopic post-operative recurrence of 42.6%. So in conclusion of this meta-analysis, it shows that the Corner S ileocolic anastomosis was more likely to decrease the risk of endoscopic post-operative recurrence at more than 6 months compared with the conventional anastomosis. So immediate post-operative complications also have been shown to be a risk of early post-operative recurrence. And they found that when one study, which was done by Cavallo, they found that it was an independent factor for endoscopic post-operative recurrence after primary ileocecal resection. So the histological factors, we have got the microscopic resection margins and histological inflammation at the resection margins. It has been found to be significantly associated with increased risk of endoscopic post-operative recessions, recurrence, and also plexitis. It has been shown that the presence of mesenteric plexitis in the proximal margins of ileocolonic resection specimens was predictive of an early endoscopic post-operative recurrence, and also the presence of granulomas and enlarged lymph nodes. So this these figures just summarize the risk factors which are associated with post-operative recurrence, like I mentioned earlier, and also including the peri-operative steroid use. It can also lead to patients having an early recurrence. So this figure, it shows how one can develop and monitor these patients. So those who have got Crohn's disease at the onset, they will have a disease education is very important. So you need to to optimize their nutrition, and the patients will be on immunosuppressive managements. And also for smokers, they need to have smoking cessations. However, those who develop complications, they might end up having surgery. And like I mentioned earlier, the operative procedure also contributes to whether the patients might have a recurrence or not. So it is important also to have the post-operative prevention strategies in place, of which you need to risk stratify your patients and you need to monitor them. Those who have got high risk, they will need pharmacological prophylaxis. In terms of monitoring, it can be endoscopically. We can have fecal calprotectin. We can have intestinal ultrasound and also enterography. And the treatment for recurrence is also needed. And for those who might need surgery, they need to be operated depending on the complications which they have. So what are the modalities which we can use for monitoring? We have got endoscopy, which is the gold standard for diagnosing post-operative recurrence. And ileocolonoscopy is needed to be done every 6 to 12 months after surgery. This was seen by the POSA trial. So we have got Rutgers scores, which predict the future clinical and surgical risks. So this was concluded after a study which was done by Rutgers with colleagues, which demonstrates that the severity of endoscopic lesions observed within 1 year after surgery at the neoterminal ileum and ileocolonic anastomosis predicted the likelihood of clinical activity in the future. So this table, it just shows the scores, the Rutgers score and the modified Rutgers scores, which is used to assess the post-operative recurrence in patients with post-operative Crohn's disease. So a score of I0 to less than I2, it shows that the patient has got endoscopic post-operative remission. And also the endoscopic findings, depending on the score, the patients can have no lesions, can have less than 5 aphthous ulcers, and also they can have more than 5 aphthous ulcers with normal mucosa in between large lesions. And those we have got endoscopic post-operative recurrence have got a score of more than I2. And those with severe disease usually have got I3 and I4, where you will find that the patient have got ileitis with diffuse inflamed mucosa, and also some might be having nodules and strictures.
We can't hear you.
Seems like my pardon?
We can hear you now.
Okay, can you hear me?
Yeah.
Okay, it seems like my laptop is frozen, failing to move to the next slide.
Okay.
Okay, just stop your share and then come back into it.
Okay. Okay, yes. So this figure just shows the lesions in the neoterminal ileum associated with the Rutgers ratings scoring, where A is just a normal neoterminal ileum, and on B is the I1 lesion, and where you can have up to 5 of those ulcers, and then we have got the I2A lesions, And also so these are the varied scoring endoscopic findings. And on E, you can find that you can see that there's a stricturing lesion. And on F, you can have a very large ulcer, of which this shows that this patient has got a very severe post-operative Crohn's disease recurrence. So in terms of endoscopic follow-up, for patients without recurrence after the first endoscopy, usually there is no clear documentation of how one can follow these patients, but we have got guidelines from the Global Interventional Inflammatory Bowel Disease Group for endoscopic evaluation of surgically altered bowel in the IBD. They recommend that subsequent ileocolonoscopy for the disease monitoring and dysplasia, it should be performed every 1 to 3 years, but that should be at the discretion of the treating physician. So the other mode of endoscopy which you can use is video capsule endoscopy, which has got sensitivity and specificity of about 50 to 79 and 94 to 100 respectively. So it's typically performed 6 to 12 months after surgery. And it has got the advantage that it can detect proximal bowel lesions, which are missed by colonoscopy. However, there is also a disadvantage that there is a risk of capsule retention due to post-operative strictures. We can also make use of cross-sectional imaging, intestinal ultrasound, where you have an increased bowel wall thickness of more than 3 millimeters, and also the presence of bowel dilatation of more than 25 millimeters or strictures. And it's very useful after small bowel restriction with an anastomosis that is beyond inaccessibility of an endoscopy. However, the diagnostic accuracy, it can be improved by using other different ultrasonographic contrast methods, where one can use small intestine contrast ultrasound or contrast enhanced ultrasonography. So the other modality which you can use is CT or magnetic resonance enterograph. And MRE, it has been it showed a sensitivity of 97.3 and with a specificity of 83.7%. And you might find that the patients with MRE, you might find that some of the patients might have a comp sign, which is a inflammation of the mesentery. The other biomarkers which you can use is fecal calprotectin, and this allows differentiation of active and inactive disease, and it also predicts the possibility of relapses and monitoring of response to treatment. So the echo workshop recommendations is to begin measuring fecal calprotectin at least 3 months after surgery, and eventually anticipate endoscopic assessments according to its levels and trends in the follow-up. So there was a meta-analysis which was published in 2018, which assessed the yield of fecal calprotectin for predicting endoscopic recurrence. And in most of the studies which were analyzed, they were prospective and defined recurrence as a Radgate score of more than I2. And the focus in terms of the fecal calprotectin, it's very important to focus on the trends values over time rather than relying on a single value alone when utilizing it to monitor for progression of disease in these patients. So while this colonoscopy is the gold standard for post-operative Crohn's disease, incorporating it with fecal calprotectin monitoring into routine care can reduce the needs for invasive procedures and enhance early detection of post-operative recurrence. The CRP and ESR, it can be used, but it's inconsistent and its measurement is insensitive to detecting early disease recurrence. There's also the use of endoscopic healing index, which is a blood test that measures 13 serum proteins that allow for the adequate identification of patients with endoscopic remission, of which there are certain cutoffs which can be used. A cutoff of 20 has got a sensitivity of up to 97 with a specificity of up to 69 respectively, while a cutoff above 50, the sensitivity is about 30 to 37 with a specificity of 88 to 100%. There are some other imaging biomarkers which are still investigational. We have oncostatin M and also serum interleukin 23 levels. And also we've got gut-specific transcriptomic signatures. These are still under investigations. So moving on to prophylaxis, the ECO guidelines, it recommends starting it in patients with risk factors for recurrence. However, according to the AGA guidelines, which were released this year, they suggest continued observation as compared with immediate initiation to medical therapy in Crohn's disease patients. We have got Crohn's disease with low post-operative risk recurrence. This was a conditional recommendation with low levels of evidence. So prophylaxis therapy, it should begin soon after surgery to limit the development of endoscopic post-operative lesions. So initiation of systemic prophylaxis therapy, it yields good results in terms of medium to long-term remission after intervention, but is also associated with a significant rate of overtreatment. So there's risk of drug-related side effects, which might overcome the potential preventative benefits in some subset of patients who would not have developed endoscopic or clinical post-operative recurrence. However, in starting prophylactic therapy based on the patient's risk recurrence may avoid over or under treatment also, but the strategy can be complicated by identifying difficulties in categorizing patients into those with high and low risk according to the presence or absence of risk factors. So which prophylactic methods we can use? We have got antibiotics, and this has been shown to reduce the risk of endoscopic or clinical recurrence by approximately 50%. So we have got the nitroimidazole antibiotics, of which metronidazole at a dose of 20 milligram per kg per day has been found to be effective, and also onidazole 500 milligrams twice per day has been found to be effective, but it has got a higher withdrawal rates due to adverse effects. So the use of these nitroimidazoles is usually limited to about 3 months, at most 12 months, since there is a high risk of adverse effects. Some patients might develop peripheral neuropathy, but you find that if you stop the antibiotics, the disease usually recurs within a couple of years after stopping them. Other antibiotics, which has been shown that of which there was no significant difference in the rates of endoscopic postoperative recurrence, was ciprofloxacin. And with the rifaximin, there was no studies which was done in the postoperative settings. So this table here just shows some of the antibiotics which have been investigated and how the results shows a reduction in the endoscopic and also in clinical recurrence. With the use of mesalazine, several studies have used different doses of mesalazine to prevent clinical postoperative recurrence, but overall there was low quality of evidence to support its effectiveness in reducing postoperative recurrence, as seen by some of these studies, which its use was investigated versus a placebo. With the use of corticosteroids, there were some randomized control trials which showed no significant difference between budesonide and placebo. And also with the use of immunomodulators, azathioprine, it may play a major role in reducing postoperative recurrence when it's used in combination therapy with metronidazole. So it has been shown to be very effective. So we can also make use of anti-TNF therapy. There was a meta-analysis of 10 randomized controlled trials of post-operative Crohn's disease, which included anti-TNF either as monotherapy or in combination with 5 ASAs or antibiotics. And it was effective in reducing the Crohn's disease recurrence compared to placebo. And also, adalimumab was found to be effective in the post-operative settings. This was seen by the POSA study. And they can be started within 4 weeks of ileocolonic resection and primary anastomosis. So in the PREVENT trial, this trial was for infliximab, and it showed that there was endoscopic recurrence where after infliximab use of about 30.6% as compared to the placebo group, which showed a 60% increase, but there was no clinical recurrence. So it was of 297 patients at 104 sites, which was worldwide. And all those patients had undergone ileocolonic resection within 45 days before randomization. So as can be seen here in this graph, that in B, you can see that there was a significant endoscopic recurrence, which was defined by Radke's scores of more than I2 in patient we had fistula or abscess criteria, and we had surgery, also we had treatment failure. But in terms of the clinical recurrence, there wasn't any significant differences. With the use of vedolizumab, there was a trial which was done for vedolizumab to prevent post-operative recurrence in Crohn's disease. This is the previous study, which was a multi-centered, double-blinded, randomized placebo-controlled trial, and it was conducted at 13 academic and teaching hospitals that was in France, Italy, and the Netherlands and Spain, of which they recruited eligible participants who were more than 18 years with Crohn's disease who underwent ileocolonic resection, and they had one or more risk factors for recurrence. And these patients were randomized and assigned within 4 weeks of surgery, some to receive vedolizumab or others to get the placebo at week 0, 8, 16, and 24. So 84 patients were randomized, of which 4 did not receive study treatment. So this left with 43 patients who were randomized to vedolizumab and 37 to the placebo group. And the ileocolonoscopy was performed at week 26. And it shows that the probability of a lower modified risk scores with vedolizumab versus placebo was 77.8%. And severe endoscopic recurrence was observed in 10 patients of the 43 in vedolizumab group versus 23 patients of the 37 in the placebo group. So they concluded that vedolizumab treatment within 4 weeks of ileocolonic resection was more likely to prevent endoscopic Crohn's disease recurrence than placebo, making it an attractive option for post-operative management in patients with risk factor for recurrence. With the use of ustekinumab, it was a small-scale comparative study where patients who were receiving ustekinumab had a lower endoscopic post-operative recurrence rate at 6 months than those on azathioprine, though the difference was primarily driven by moderate disease rather than the severity of recurrence. And when comparing ustekinumab to vedolizumab, both drugs, they showed similar rates of endoscopic success. That was 50% for ustekinumab versus 47.6% for vedolizumab, and also with clinical failure, that was about 27.3% for ustekinumab and 32.8% for vedolizumab. Other advanced therapies which can be used, although there were no direct studies which have evaluated these advanced therapies, They are demonstrated efficacy in the induction and maintenance trials for patients with Crohn's disease suggest that they've got a potential role in these settings. So we've got abatacitinib, and also we have got risankizumab, we have got infliximab subcut together with vedolizumab subcut, and also mirikizumab and giselkumab. These are some of the advanced therapies where further clinical studies needs to be done to show their efficacy in patients with post-operative recurrence of Crohn's disease. So modalities which have been shown to have minimum or no benefits include the amino salicylates, budesonide, like I mentioned earlier, and also probiotics and vitamin D and curcumin, which is an active compound in turmeric. So this figure is just summarize how we should manage patients who have got post-operative Crohn's disease, the importance of risk stratifying your patients into low risk and high risk, and all those who have got high risk, those who have got more than 2 surgical interventions or penetrating or perianal disease, or those who are active smokers to receive anti-TNF or denosumab or either other biologics or small molecules depending on their availability, and also the importance of monitoring ileocolonoscopy and also fecal cow protecting, and also in terms of those we have got no recurrence, to do the colonoscopy once in 3 years, every 1 to 3 years, depending on the risk factor and the clinical findings you have on those patients. However, in these patients, we have got post-operative Crohn's disease. You might find that there are some certain concomitant diagnoses which you might need to think of when you are thinking that your patient has got post-operative Crohn's disease. So some patients might be having bile acid diarrhea, especially those who have got iliac resection of less than 100 centimeters. And some might have a fatty malabsorption. Some might develop small intestinal bacterial overgrowth. And some who have got repeated surgeries might have short bowel syndrome. And some of these patients might develop vitamin deficiencies. And some might be having irritable bowel syndromes and also chronic abdominal pains. And some might even develop surgical complications needing further surgeries. So one has to think of these concomitant diagnosis in these patients, and they also need to be worked up for, so that you rule them out for you to say this patient has got post-operative Crohn's disease. Of course, with the use of Radke's scoring, you might easily identify it, but it's very important to rule out these other concomitant diseases. It's like a freeze. Okay, so in conclusion, early intervention and proactive monitoring, they are crucial for optimizing long-term results in the post-operative settings of Crohn's disease. And of all the risky factors, as you have seen, smoking is the only modifiable environmental factor. And as such, personalized treatment plans, they need to be used based on the individual risk factors and biomarkers. And for patients who have got high risk disease of recurrence, infliximab is recommended as the first line, while ustekinumab and vedolizumab can be used as second line options depending on the availability. And also further studies are needed to provide evidence-based treatment algorithms and validate tools to risk stratify these patients. That's the end of my presentation. Thank you.
Thank you so much for your talk. Quite comprehensive, and it has a good overview on the topic. I'll open the floor to questions and comments in the chat. But while we're waiting for people to think about it, I'll make some comments. So surgery and Crohn's goes together. Most Crohn's patients, as Godknows said, 30 to 80% will have at least one operation. And if you have one operation, you may need a second operation or a third operation. Hopefully, over time, we've gotten better at delineating and not allowing patients to burn out and come to the end of the disease process, and then we do surgery. So I think we should get better at risk stratifying and choosing when to have the surgery at the appropriate time with our medications. Okay. Second comment. So the two main risk factors is smoking and the history of previous surgery. If you look at all the other risk factors, that just shows the risk factors for severe Crohn's disease. So you just need to carefully evaluate that. Types of surgeries. Godknows, do you know what type of surgeries do they have they done over the years? Because you may have seen somebody who had a surgery 30 years ago or 20 years ago.
Pardon?
Any
Can you repeat
comments on
the
that?
question?
Surgeries. What type of surgeries are done on Crohn's patients and then anastomosis?
Okay, so we have got they've got the classical end-to-end anastomosis. Then we
Okay,
also
good.
they can have the corner S anastomosis, which has been shown to be more effective in terms of reducing recurrence because the mesentery is not involved.
So important to know that. So some Crohn's patients can have discontinuation of the bowel. So I have a stoma or a loop
Yes.
ileostomy or something else, a loop colostomy or anything else. Okay. So I think the important thing is that if you have no continuity, less recurrence, continuity comes with when you rectify that, when you have continuity. And the most common procedure done in the past was an end-to-end anastomosis. What was the recurrence rate in that patient population? High, low?
The recurrence rate it was high.
It's high. Why do you think that
Yes.
happened?
With the end-to-end anastomosis,
Mm.
most of the time you find that there's fecal stasis, and
Mm.
it kind of promotes fecal stasis, and this can lead to activation of the pro-inflammatory state, leading to recurrence.
Okay, so
Yeah.
so end-to-end had a very high recurrence rate, but also high stricture rate. Can you get an idea of why? So I think the important thing there is one of the theories behind why the terminal ileum is most commonly involved in Crohn's is shear forces. So if you look carefully at your bowel, from going from your TI into your cecum, through your IC valve, that area has the most shear forces. That shear forces can be perceived as a body as a noxious stimulus, which stimulates more inflammatory cells coming to that area, which then does damage, and that's why you have active disease. With end-to-end, it is you're having a smaller lumen attached to a larger lumen. Both lumens have different frequencies in bowel movements. So you can imagine that the shear force of that area is very high. You get a lot of inflammatory cells, and then you can have recurrence plus or minus stricturing. Why do you think Kono S helps or is better? So end to end. Then what was the next most common operation done that Echo
Uh,
recommended before Kono S?
End-to-end, and I'm not sure the next
So
recommended
they
one,
recommended first a side to side anastomosis.
or the side-to-side
So you
anastomosis.
trying to take the bigger surface area, test the bigger surface area. Have you scoped many post-op Crohn's patients?
Uh, I haven't.
So sometimes you got a very good end-to-end anastomosis. So you're trying to make a J on either side and attach at the bigger surface area, the small bowel to the large bowel. In a very good side-to-side anastomosis, you sometimes go past the anastomosis and come to the blind loop of your colon. And you actually have to come back carefully to see. So then it actually creates like a ball value effect that you don't have lots of dumping of your stool straight into your colon. Okay. So that's the thing. And then Kono S is the new kid on the block. So why do you think Kono S works?
So with the corner S, uh, there is a with the corner S-based thing, it's more of the supporting column. It prevents distortion, so there's kind of free movement.
And so it allows a nice surface area. So you're taking lots of mesentery out. You're filling that space.
Yes, and also,
so you're making a few anastomosis, and you're making a common area which probably allows less stress or less shear force at that area. So it's probably the mesentery plus the way the operation is done. Okay. Of your monitoring, what do you think is a growing way of monitoring patient post-operatively?
I think the use of the use of fecal cow protecting is very important.
Okay, let's discuss that a little later. But before that, so you said
the ileocolonoscopy is the gold standard. Yes.
Imaging. And what else? Ultrasound. What do you think of ultrasound?
Ultrasound is very important. It's easily accessible and it's non-invasive. So you can easily get the
investigation.
And it's a best,
so
yeah,
I think that's going to take off. And then if one user uses it all the time, and you look at the analysis carefully and you're good at it, you probably can pick up things much earlier than you probably pick up with other modalities. Okay. Coming back to, so you said Rutgers. If you see one or two ulcers, are you allowed that? Is it normal? Is it shows disease process? What do you think that small ulcers, one or two ulcers in Rutgers 1 or 2 comes into play?
It's if it's 1 or 2 ulcers, the scoring is less than I2. So I would monitor that
normal?
patient.
Is it a normal variation or disease activity, or are you allowed to have that? What do you think about that?
Studies have shown that you can be allowed to have that.
And what
but you need close monitoring. Pardon?
On what basis is that ulcers? From the disease itself or something else?
Highly unlikely from the disease process.
So you allowed it?
I think you might need.
So even in non-Crohn's patients, sometimes you see ulcers as anastomosis. And that's most likely due to ischemia, either from the surgery or the staple margin. So that's why it's not thought to be active disease. Okay. Keeping on Rutgers developed a score, and what anastomosis did they do at the time?
It was the end-to-end anastomosis.
So they did it end-to-end. So anything other than end-to-end, how applicable Rutgers should be taken into context.
Yes.
Okay? But the concept of Rutgers is the important thing, rather than just the thing. Before we go further, if everything was equal and you had all modalities and all therapies available, what would you do with a post-op Crohn's patient? What would you do? It's in a stepwise manner. So you've done all the reading, you've done all the literature review. So if you could do anything and everything under the sun, well, what would you do? And in what sequence?
So in terms of sequence, I'll start with the fecal cow protecting maybe at 3 months. After taking the risk factors for each patient, then you have to do the fecal cow protecting, which I will need to do it serially and follow up the trend. Then I'll move on to ileocolonoscopy.
So say now fecal cow. So fecal cow, what's the caveat there? What's the caveats with fecal cow and post-op?
The caveat with fecal cow protecting is sometimes it's difficult to get it from the patients to submit the specimens.
No, that's not the issue.
Yeah.
It can be positive post-operatively and up to 3 months afterwards.
Oh.
Just from the operation, it doesn't mean disease activity. So I don't think you can purely rely on that. Anything about cutoffs?
You might need
fecal cow?
The cutoff. It just varies on the studies. Some say 100. Some will say 50.
150.
Yeah,
some say less than 50. You shouldn't worry. It's fine. Okay. So that still needs to delineate in the literature in terms of how heavily we rely on it. Okay.
Okay.
So now your fecal cow is fine. 6 months later, all
6
normal.
months later, they now do ileocolonoscopy. And
if a patient is doing well, so the guideline says 6 to 12 months. So when would you decide? Why they give that such a range?
They give you such a range because at times some patients might have maybe endoscopic changes before they can show it clinically.
Yes.
So you need to
I'll
be
give you an example. So
proactive.
now you have a patient at 6 months, you scope them, but at month 8 and 9 they have symptoms. Are you going to rescope them?
I think I'll consider giving them prophylaxis if they've got
Prophylaxis.
symptoms.
What prophylaxis?
Depending on the availability, you can give them anti-TNFs, or you can give them.
But you see that in my head, prophylaxis is immediate prevented. You're talking about escalation of therapy. Okay, so you must separate those two concepts in your head. So that's not prophylaxis. That's treatment now.
If they have already developed, now they will need treatment for Crohn's disease. So it will be better to give them biologics. And then you need frequent monitoring. Yes. Okay. So the biologic which you give will depend
so
on
when you talk about prophylaxis,
availability.
what do you mean? What should the only thing in prophylaxis?
Prophylaxis is you are preventing the recurrence of
So what's the only thing
Crohn's.
that you presented in your talk about prophylaxis?
Yes. So for patients who have got prophylaxis, you can use antibiotics, you can use immunomodulators.
So don't you think every patient should get antibiotics?
It depends on the guidelines which you can use. Those with low risk, you might consider monitoring them without antibiotics.
So the newer guidelines,
to high
if you look
risk.
back at the guidelines, the guideline was always first, everybody gets at least 2 to 3 months worth of flagyl. Okay?
Yes.
Low risk, medium risk, because if they can tolerate it, you're losing nothing. And you can prevent something. Okay? So the old adage was the low risk patients flagyl, the medium risk patients had flagyl plus azathioprine, and the high risk patients would be initiation of biologics early. Okay? Yes. This is now evolved into this thing about should you or shouldn't you give prophylaxis. Personally, I would give flagyl to everybody. You lose very little and you can gain a lot. Okay? So prevention would be azathioprine, infliximab, adalimumab, vedolizumab, ustekinumab. Okay? And there's a lot of evolving data with regards to that. So the issue why I ask you about the colonoscopy at 6 months and the patient has symptoms at 9 months, sometimes we don't work in a perfect world. Sometimes patients don't want multiple scopes. Sometimes people on medical aid, if they have a second scope within a year, they must pay a co-payment or they must pay for it and they don't want to do that.
Yeah, so maybe you might now consider other modalities like your intestinal sauna and MRE if it's available.
Okay. Yeah. So that's all expensive machines. So in my head, everybody should get flagyl if they can tolerate it for up to 2 to 3 months, 400 BD. Then you have to risk stratify. If a patient's doing well and the fecal cal, whatever you're doing is well, I'll probably delay this scope. Because if you're going to scope somebody at 6 months, if you find anything, you need to escalate therapy. We also don't want to miss them by scoping them too early. Okay, then it's a balancing act. So if you look at the big meta-analysis or network analysis, they're using infliximab as the reference point. So anything does better or worse than that. So what do you think? As you said, 5A says a no-go area doesn't work. Other antibiotics doesn't work. What do you think about azathioprine compared to infliximab?
Azathioprine compared to infliximab, it works.
So azathioprine works, but not as well as infliximab.
Not as well, yes.
Adalimumab and versus infliximab?
It also does work, but not as much as infliximab. But they were very small.
Adalimumab works, but not
studies.
as well. Then adalimumab plus azathioprine against infliximab.
They were more or less comparable.
No, so actually infliximab is better than adalimumab and azathioprine. Okay, and the two drugs that still does better than infliximab is Vedo and ustekinumab. Or everything else we don't know enough information about. Okay. Any questions from the floor? Any comments from other consultants on? Anybody want to add something to the discussion? So I think there's a common thing. We will see it, and we'll continue to see it. Although we're doing less and less operations, this post-op prevention is an important thing. So just please remember that sometimes in early on Crohn's, in limited disease to TI, an operation can, after flagell, patients can go up to 10 years without any medication. And that in chronic disease like Crohn's is an important thing. So there's less risk for medications, less risk for side effects of medications, less risk for infections, less risk for the thyroid-related lymphomas or other diseases. So in surgery is an important thing, and then monitoring these patients carefully. As you can see from the presentation, there's a lot of individualization. Very good randomized controlled trials will probably be unlikely because it will be very difficult to compare apples to apples. Because I'm sure all of us who've seen lots of Crohn's patients, all of them are slightly different. No two patients are exactly the same. And so all the studies that come out from this will be difficult to interpret in terms of comparability in terms of all patients. If there's no other further comments, we can close on time. Thank you so much, Godknows. Any last comments you want to make?
I think it's just the importance of risk stratifying the patients and also using the available biologics you can have. And like you said earlier, for all the patients we have done surgery, it's very important to give them the metronidazole or as prophylaxis. All the risk of adverse effects are there, but they outweighs the benefits of them receiving the prophylaxis. Yeah. Thank you.
Thank you so much. So if no other comments, no questions on the chat, we can end our session. Thanks so much to Godknows for the good presentation. Thanks to iEcho, University of New Mexico, and the iEcho India team for the support. Recordings will be available on the Gastro Foundation website. And thanks again to the Gastro Foundation. Thank you so much. All of you have a good evening. Thank you. Bye-bye.